My name is Brad Vincent. I'm one of the pulmonologists at the lake. I'm originally from New Iberia, and then med school in Shreveport, and then I was in Charleston, South Carolina for 7 years for training, and then moved back here to Baton Rouge about 5 years ago, and I've been here ever since. And my training was specifically focused on lung cancer and intervention for lung cancer, bronchoscopic techniques and things like that. So I'm sort of, it's what I do. I do lung cancer, lung nodules, lung imaging, and diagnosis, and really staging for lung cancer. And so they asked me to talk today about screening. It's a big theme, obviously, here at the forum today is screening. So they're screening for cholesterol. They're talking about screening for prostate cancer, and cancer screening in general is a very important topic to healthcare in general. So screening for surgically resectable or removable lung cancer. So quick show of hands: smoker, former smoker, smoker, never smoker, never smoker. Okay. And any of you guys have close friends, family members, lung cancer? Okay. Most everyone. I mean, my aunt died of lung cancer. I had another great aunt die of lung cancer. So because it's such a common cancer, most people either have had a close family member or friend either with it or die from it. All right, so quick overview. Lung cancer, even in 2012, still the largest cancer killer of men and women. And it has been for the last at least 3 decades. It occurs almost exclusively in smokers. I mean, you still hear about people who never smoked who develop lung cancer. It's pretty rare. I've seen, I think, 2 or 3. And Louisiana has one of the highest incidences of lung cancer in the country. Overall, roughly about 85 cases per 100,000 population. That's pretty high. So a lot of people say, they have a hard time understanding the concept of cancer. So they say, well, so-and-so died of cancer. And then the inevitable next question is, well, what kind of cancer? I don't know, cancer. So a lot of people don't have the explanation of what cancer is and how different it can be in different parts of the body and different organs. So cancer is the Latin word for crab. So there's the constellation of the crab in the sky. Hippocrates, who's the first physician, the first recognized physician in recorded history, first noted that when he was doing autopsies of people who had died, he cut into the surface of whatever organ he was examining, the liver or whatever. There was a tumor that had radiations growing out from it, and it looked like a crab, so he called it cancer. This is what lung cancer looks like. So here's lung, and then we have emphysema, which, emphysema you can basically think of as soap bubbles in the lung. It's destruction of lung with basically leaving a hole. And then here is your tumor with these radiations coming outward, here, sort of here, and here. So again, like we said, cancer is a broad term. Cancer can occur in any solid organ, such as the brain, the liver, the kidney, and also your blood organs. You hear somebody talk about they died of blood cancer. Well, there's, again, a lot of different types. There's leukemias, there's lymphomas of the lymphatic system. So it's a pretty encompassing term. And each organ has its own variety of cancer subtypes. For instance, kidney cancer, there's probably 15 different types of kidney cancer that when you look under the microscope and do specific markers, you can determine what cell, what type of cell inside the kidney that cancer originated from. So cancer basically results from abnormal cell growth and abnormal behavior of those cells. So not only is it uncontrolled growth of a clone of these cells, but they behave differently. They lose their ability to recognize their surroundings. They gain the ability to essentially survive as single cells and implant in other organs or metastasize. So why do they occur? There's a lot of different reasons. There can be environmental factors, such as exposures to toxins, genetic factors. Some people have just a genetic predisposition to developing tumors. And then the loss of control means that each clone of this individual cell will grow quickly, and it will grow independently of all the normal control mechanisms. So the part of the cell that says, stop growing, you've grown enough, or stop dividing, is gone. And then, like I said, these tumor cells can travel to distant sites in the body and basically set up another little clone of themselves and reproduce. So lung cancer is a cancer, which we just described, that occurs in the lung. So one of these cell types starts growing into a cancerous or tumor cell. And there's two basic varieties of lung cancer: small cell cancer or oat cell cancer, and non-small cell cancer. Non-small cell cancer involves every other subtype. Small cell is treated very differently. It's its own sort of entity. They have different biology, and they're treated differently. So small cell cancer of the lung, the approach, the staging, and the treatment is different. And small cell is about 20%, just under a quarter of all lung cancer cases in this country. So we'll talk briefly about small cell. Very aggressive. Very aggressive. It metastasizes early. And it's derived from hormone-producing cells inside the lung. And what can happen is, as the tumor grows, it produces these hormones independently, and they're always turned on. They're making this hormone all the time. And that can lead to some very unusual findings in the body because of the effect of these hormones. And it's something called a paraneoplastic syndrome, or because of the neoplasm, because of the cancer type syndrome. And so surgery for small cell is generally because somebody developed a small nodule or tumor, goes to the surgeon takes it out, and they look at it under the microscope and say, oh wow, this is a small cell. That's generally the only time that you would hear about surgical resection for small cell cancer. It's very rarely discovered early. It's usually just found incidentally. And it's more often discovered at a fairly late stage. Once you have the late stage disease, you can expect to live anywhere from 8 to 12 months, even with the best treatment. 5-year survival, 1 to 5% will still be alive after 5 years. So non-small cell lung cancer, which accounts for 75 to 80% of all lung cancers, includes all the other subtypes of lung cancer, the most common being squamous cell carcinoma and adenocarcinoma. Squamous cell is derived basically from the lining of the air tubes. Adenocarcinoma is derived from the glands inside the lungs that make mucus. Other types are large cell, bronchoalveolar cell, and then mixtures of these. And when we talk about cancer, we can refer to the stage, which is the extent or spread or size of the tumor, and we can also talk about the grade. The grade of the tumor indicates the appearance of the cells and how rapidly it's dividing and how aggressive or angry it appears. And like I said, the stage is determined by not only the size of the tumor, but also by lymph nodes. One of the earliest places that cancer likes to metastasize to, and that's from any cancer, pancreas, liver, breast, lung, is the lymph nodes. And lymph nodes are everywhere in our body. They're normal part of our immune system. They filter the water component of blood. When you take blood and you let it sit out in a tube, it develops the red cells and then the plasma. So the plasma part of the blood all gets filtered through our lymph system. And what the lymph nodes do is they're like the CIA. They kind of look at everything that passes by, and they are looking for suspicious characters. The problem is that a lot of times these tumor cells will get into the lymphatic system and lodge in a lymph node because it's the first place that drains these areas of our body. And then once they're in the lymph node, they can set up shop and grow inside the lymph node. And this is what small cell cancer looks like under the microscope. Just a bunch of clones, basically, of these small cells. Just all arranged in a haphazard sort of arrangement. This is what squamous cell. Hey guys, sorry for just starting, so not too far in. Just going over a little bit of what lung cancer is. So here's squamous cell cancer, and it's a little bit more organized, and you see these little sort of whorls here. That's basically the same stuff in here as what's on the surface of your skin, keratin. This is adenocarcinoma, and this is forming sort of a very disarranged mucus gland inside the lung, but it's a cancer. All right, so when we talk about lung cancer, we'll talk about some of the causes or known causes of lung cancer. Number one, first and foremost, far and away, the most common, tobacco smoke, cigars, cigarettes, pipes, what have you. Radon gas was the first recognized cause of lung cancer. It's a decay product of radioactive uranium and radium. So the uranium miners in Europe back in the late 1800s, early 1900s started developing lung cancers, and it was from radon gas. Asbestos fibers, secondhand smoke or secondary tobacco smoke exposure. The best research we have shows a 20% increased risk of developing lung cancer with long-term exposure. Then there's some inherited forms of lung cancer. And then one that's under-recognized actually is a chronic inflammatory or infectious part of the lung. So somebody who had tuberculosis and healed, in the 1940s, 40, 50 years down the road develops a lung cancer. And oftentimes it's in the area of scar inside the lung where that tuberculosis healed. It's a so-called scar carcinoma. So one of the first people to make the connection between cigarette smoking and lung cancer, Alton Ochsner. Very influential. He was originally from South Dakota, trained in Washington State. And when he was a trainee in Washington State, when he was an intern, one of his professors told him, "You need to come and watch this autopsy because you may never see another case of this." It was lung cancer. This was in the late 1800s, 1897, I believe. That's how rare it was during that time. They said, you may never see another case. So fast forward to the 1920s, 1930s, and a lot of vets returning home from World War I. Dr. Ochsner was at Charity in New Orleans, and in 1 year he saw 6 new cases of lung cancer. All in returning World War I vets. So here are some debatable causes of lung cancer. Heavy metal exposure, such as cadmium, beryllium, chromium, arsenic. Agent Orange, 2,4,5-trichlorophenoxyacetic acid. Probably the strongest correlation of these is industrial and city air pollution. Higher lung cancer rates in cities with higher levels of air pollution. Nitrogen dioxide and some of the sulfides that are contained in acid rain and things like that are recognized causes of cancer. So here's the lung cancer map. from 1970 to 1994, 24, 25 years of data. Here, so red being the highest rates, and you can see even Louisiana separated by parish and region. And here's the cancer belt right here. It goes from eastern Texas up through Arkansas, Missouri, up to Kentucky, over to North Carolina, and down to the panhandle of Florida. This is your cancer belt, with another belt being up here actually in Maine and New York. Alaska, no real data. Hawaii, very low. The Midwest and West, pretty low. Again, this is just sort of going and showing the same data, but giving you the number per 100,000. And you can see the states with the highest lung cancer rates are here. Kind of a outlier there in Las Vegas and Maine. Yeah, and sort of radiating out to the tobacco belt here, with South Carolina being a little bit lower. But yeah, the Mississippi River Valley going, you know, one state either direction is pretty much it.
What factor is used to determine this in the southeast?
Do you mean why does this look the way it does?
Yeah.
Smoking. When you look at smoking rates, it's a virtual mirror image of this.
So you could say that there are more smokers in that southeastern part of the country.
Yes, the highest incidence of smoking occurs right here. Mm-hmm.
Not because of sunshine or whatever.
No, and there's correct. There's been a lot of debate. There's been a lot of, you know, studies, actual epidemiologic studies, looking at, is there a factor based, you know, is it pollution from the Mississippi River? Is it industry along the? But when they factor in all of those things, there's really nothing that they can come up with concrete. I mean, you've probably, like I did growing up, hearing about Cancer Alley, you know, here in Louisiana. One of the oncologists here in town, Dr. Fred Billings, years ago did a very detailed analysis and basically came up and the cancer rates in Cancer Alley are actually no higher than anywhere else in the country. Mm-hmm. But when you have clustering of cancer cases, and especially odd or unusual cancers, inevitably there's talk of, well, there's got to be something there. And while I'm not saying that's not the case, there may be something there. It's nothing that we can identify. But here it's clear that the highest smoking rates are in these states.
Yeah, about 74 to 99%.
Mm-hmm. Well, this is per 100,000. So out of per 100,000 population, this is the number of cases that you have, from 74 to 99, and even higher than this, actually. And so I know this is small print, but what I'm going to show you here is, so this is new cancer cases and deaths. So this is cancer cases, all new cancer cases in the United States for estimated for 2012.
Very recent research.
Yes, this is the latest data from the CDC. All types of cancer in both male and female, estimated 1.6 million new cases. All of the digestive system, including colon cancer, esophageal cancer, 284,000. Lung alone, 226,000. Breast, 229. Prostate, 241. So those three are fairly equal in incidence, lung, breast, and prostate. But when we look at cancer deaths, we have lung, 160,000, breast, 39,000, and prostate, 28,000. So you can see the difference here. It's roughly 4 times more common a cancer killer than breast, and 5 times more than prostate. Those are the 3 most common tumors diagnosed in this country. And so here we have Louisiana down here at the bottom. When you look at the cancer rate for males, 105.8 per 100,000. That's in the top 10 at least. The only one on this page that are higher are Arkansas, Alabama, and Kentucky. 130 per 100,000 in Kentucky. Then when we look at females, it's quite a disparity actually. For Louisiana, females is 58.6 per 100,000. Still pretty high when you look across the board.
Is that also a mirror image between male and female, the smoking pattern?
Yes. Yeah, roughly 2 times as many males smoke compared to females. So here is the 2012 estimate of cancer deaths. Lung cancer, for males, 87,750. Look at females even. So roughly twice the number compared to breast cancer. So lung cancer still kills twice as many females as breast cancer. And then when you look at the percentage of all cancer death, almost 30%, almost a third is lung cancer. The next closest is for males is prostate at 9%. For females, breast is 14%. So you can see what a huge epidemic this still is. And so when you look at the last roughly 20 years of lung cancer incidence, so occurrence of lung cancer, it's actually come down, not insignificantly. And that is purely a reflection of the decreased rates of smoking. It's mirrored the rates of smoking decline in the United States over 20 years. Same with lung cancer mortality. It has decreased, not dramatically, but significantly over the last 20 years. And this is from all causes. The highest percentage of decrease in lung cancer death is actually in black males, right here. So black men are getting the message is smoking's bad.
How is prostate cancer identified?
Prostate cancer?
X-ray or what?
Generally biopsies and surgery. White males, sort of flat, but not decreasing as dramatically. And then females kind of went up during that time period and has sort of leveled off. So it's been pretty level. So here are the 5-year survival rates for these common types of cancer at time of diagnosis by stage. So breast cancer, if you get diagnosed, regardless of what stage it is, you have about an 89% 5-year survival. That's pretty good. Colon cancer, 64%. Esophageal cancer, 17. Kidney cancer, 70. Larynx, or your voice box, 61. Liver, 14%. Lung, 16%. And then when you look at lung cancer, you can see the rapid drop-off. So when it's a small tumor, when it's confined, 52% 5-year survival. When you have one or more lymph nodes involved adjacent to the tumor, it drops off to 24%. And then when you have a metastasis somewhere else, 4%. So that's a pretty rapid drop-off. So we're talking about lung cancer mortality here, and it's highly lethal. It's a killer. Most cancers that we talk about, breast, lung, prostate, colon, when they look at the mortality data, they look at 5 years. It's sort of the standard is 5-year survival. Lung cancer survival actually correlates quite well with the stage of diagnosis. So early stage lung cancer, your 5-year survival, like we said, is 50% or higher. Once it spreads to the lymph nodes, it drops off quite dramatically. And when you look at the last 50 years, there actually has not been that much of a decline as one would expect given advances in medical treatment in lung cancer mortality. Most of the improvement in lung cancer mortality is simply due to less people smoking.
What do you attribute that to? The decrease in the mortality rate?
Simply because less people are smoking now. as compared to 50 years ago. Yeah, a smaller percentage of the population smokes. So why have we not seen a dramatic decline in lung cancer given advances in imaging and treatment and medicine? Because of this. Because this is most commonly when your tumor is diagnosed, when it's this size, right here. Early lung cancer frequently is asymptomatic. You don't have symptoms. Doesn't cause weight loss, doesn't cause bloody cough, doesn't cause problems until it gets to be about this size here. And by the time you have symptoms, it's already too late. So here you can see cancer that has spread to either the lymph nodes or to another site in the body represents 78% of lung cancers diagnosed in the country. That leaves a small percentage of lung cancer that's actually diagnosed at an early stage, when it's still small and still confined to the lung. That's why our survival rates are so terrible. So here's just some graphic representations of the different stages. Here's stage 1, tumors there, lymph nodes sort of along the bronchial tree here. And there it is. That's still a curable stage. Stage 2, it has spread to this lymph node and will rapidly spread to the other lymph nodes in the area. Stage 3, there's stage 2. In each stage, there's an A and a B subclassification, but stage 3A and stage 3B actually, it becomes important because surgical removal is still an option at stage 3A. At stage 3B, it's really not. But here you see the larger tumor. It's grown considerably, and it's involving not only the regional lymph nodes, but also the lymph node in the midline, just under the windpipe, and even can go across to the other lymph node. Once it crosses to the other lung lymph nodes, it becomes 3B. And look at the survival. So when you have a large tumor but no lymph nodes, 33% 5-year survival. When you have a large tumor and one lymph node nearby, roughly the same, 39%. I don't know why. This is probably just not statistically significant. Roughly the same. Once you have what we call N2 nodal disease, so it's spread to this lymph node one space away, drops to 15% 5-year survival. And then once you reach stage 3B, that means other lymph nodes across the chest or higher up, it drops off to roughly 8%. Stage 4 is a tumor in the lung of any size with any lymph node involvement that has already spread outside of the chest. So here's a picture of a tumor inside the liver.
Now that 8% that you mentioned was a survival rate?
5-year survival. Mm-hmm. All right, so cancer screening. You hear a lot about it here today at this forum. I sort of liken it as the panning for gold. You have to sift through a lot of crap before you get to some gold. So here are the basic principles of cancer screening, and this holds true for any type of tumor, not just lung. So your screening test must have a high sensitivity. That means when you have the cancer in your lung, this test picks it up. It has to have a high specificity. That means when you don't have lung cancer, the test is negative every time. In other words, it's not going to be a test that's positive when you don't have lung cancer. It has to have what's called a high positive predictive value. That means when the test is positive, there's disease present. And a high negative predictive value. A negative test means you are free of disease. You can sleep at night now. So the disease itself, number one, should be a common disease. Screening for a rare disease is problematic. It has to be common. The burden of disease should be enough to warrant screening. So screening for a disease that causes little to no problem is not worthwhile. you must have an effective prevention or treatment available for the disease. Screening for incurable diseases is not a good thing. If you don't have treatment, if it's not something that you can prevent or cure, then screening is really not beneficial. And the test and treatment should be available to the public. It shouldn't be something that you can only go to one center in Rochester, New York by one doctor, and it's not feasible. So here are the problems with cancer screening in general. You have what's called bias. So if I take 1,000 people and screen them all for prostate cancer, I'm going to find some prostate cancers. That's what the purpose of screening is. But you have these inherent problems such as what's called lead time bias. So when you go to analyze your data and look and see how many lives did we save with this screening, well, part of it is that you diagnosed a lot of very small prostate cancers that maybe would have never developed into big prostate cancers and maybe would have never caused trouble for that person. So it's hard to say whether or not you saved that person's life, but you put them through a prostatectomy. You have length bias and overdiagnosis. Overdiagnosis means finding a lot of problems and a lot of tumors inside the lung. But it, again, may be tumors that they never would have died from. Not only that, but a lot of people who do not necessarily need testing or treatment will get testing and treatment based on your screening test. There's the stress and anxiety of a false positive test. I see this every day. I get people sent to me with lung nodules. And there's, a lot of them are. A lot of them are scars or what have you, things that are benign that are not cancer. But it's very stressful for somebody to be told they've got a spot on their lung. And that inevitably can lead to testing or surgery for these false positive tests. That's nothing to sneeze at. That's a big risk.
When you do surgery, like do you remove part of the lung, or how does it affect the patients after surgery?
Yeah, part of the lung's removed. It depends on how much of the lung is removed, depending on what the underlying problem is. But yeah, part of the lung can be removed.
How does it affect the patient after the surgery?
It depends on how much is removed. Sometimes if a lot of the lung's removed, people can be short of breath more easily. You have less lung capacity. There's a healing time involved, which is months to get back to normal. So yeah, it's not an easy procedure. It's not a day surgery for sure. There's the false sense of security of a negative test. So somebody gets a screening CAT scan or a blood test and it's negative, and well, I'm going to go out and smoke a pack of cigarettes. Woohoo! There's the potential harm due to the effects of the test. So for instance, CAT scan screening exposes you to radiation, or procedures done because of the screening test. So here are the current screening tests available. Colonoscopy for colon cancer. There's clear benefit for colonoscopy demonstrated in the medical literature. Pap smear for cervical cancer for women, clear benefit.
What percentage of what percentage of folks go through this?
Maybe a quarter, maybe. Yeah, it's on the rise. I mean, more people are getting the message, but yeah, it's not as many as you would think. PSA, there's Dr. Morris has given a talk about PSA screening. Very debatable subject right now, whether or not it's worthwhile or confers benefit. Mammography, same thing. Very hot topic. It's become highly politicized. So there's no screening test for ovarian cancer. There is a blood test that's going to be available probably in the next 5 years that will have to be researched to see if it saves lives. Pancreas, again, you might have seen on the news, there was a high school senior I forget where, but developed a blood test that's a screening test for pancreatic cancer that's in testing right now.
That's new, is it?
So lung cancer screening. So here's a brief history of the studies. It started in the late 1960s. Two big ones, the Czechoslovakian study and the Mayo lung study. What they did is they took people and they took just a plain chest x-ray. This is pre-CAT scan era. Every 6 months. And then they had them get a deep sputum from their lung as much as they could in a cup, looking at it under the microscope, looking for cancer cells. So they did find more lung cancers. But when they looked over time, the rate of lung cancer death did not change. Even with finding early lung cancers, the overall mortality rate from lung cancer didn't change. So in the late 1970s, early 1980s, CAT scanning became much more commonplace because it became cheaper. And the devices became smaller. And it gives orders of magnitude more information more than a chest x-ray. Much more data. So in the 1990s, we were able to reduce the radiation dose of a CAT scan significantly, on the order of down to about getting 3 chest x-rays. So the amount of radiation that they give nowadays with CT is quite low. And they also improve the resolution of the imaging, where you can see now down to nodules smaller than a centimeter, and oftentimes down to about 3 and 4 millimeters in size. CAT scan for lung imaging is far, far superior to MRI. People ask me all the time, should I get an MRI of my lung? The answer is no, because your lung is full of air, and MRI is terrible for looking at anything with air in it. So they said, well, let's use this CAT scan and use it as a screening tool and see if we can change the outcomes for lung cancer. So here's just a chest x-ray showing a lung tumor right there. Here's a CAT scan showing a lung tumor. You can see the difference in 3 dimensions now. The way I explain to my patients about CAT scanning is, imagine you're a loaf of bread. And now we can take each slice and look at it front and back and get dimensions. And that's compared to just looking at a picture of a loaf of bread, which is what an x-ray is. So here, when we're looking at the CAT scan, here's the front, here's the back, here's the table right here. You can see this person's breastbone right there. Here's the right side and the left side. And what you have to imagine is this person's feet would be about where the door is here. The person's head would be in the next room behind us. And what the CAT scanner does is basically slice by slice go down towards the feet. And so this is just one slice. If I were to take just a section of me right about here and just pull it out, that's what we have represented here. And so here's the right lung here, the left lung here with the tumor. Here's the windpipe right in the middle. And then these are the blood vessels. Here's the aorta, the blood vessel that comes off of the heart. And then here's the spine back here. So when they looked at these large CT scan screening trials, there were two major types of these studies. One is called a cohort study. So you have a cohort of people. Cohort's just a fancy term for a group of people that are similar, that have some similar characteristic, smokers or what have you. And they looked at these similar patients over time to determine whether or not the screening results in a change in their outcome or cancer death. The second type of study, which most epidemiologists would agree is the superior type of study because of the way it's designed, is a randomized controlled trial. So you have a cohort of people, similar characteristics, and then you randomly assign them to 2 different types of treatment. One which they generally assign to what's called standard treatment, to whatever the medical standard is at that time. And then the other group to whatever you're looking at as far as, intervention, that's the screening. and see if there's differences between those two groups. And so they looked at 5 randomized controlled trials looking at CAT scan versus the usual care. In those 5 studies, there were roughly 23,000 patients, and then they looked at them for about 33 months of time, so about 3 years. All of them failed to show improvement in lung cancer death. Then they looked at 3 different trials comparing, let's just compare CAT scan to chest x-ray. Maybe we're just not diagnosing them small enough. X-ray's picking them up, but not small enough. CAT scan will. So the NLST, National Lung Screening Trial, was the largest of these trials. Multiple center study over 5 years, 53,454 patients. They did 3 annual rounds of screening. They did a baseline screening with CAT scan, then one at 1 year and one at 2 years. So this data just got analyzed not even a year ago. They finalized the study, and what they found was there was a 20% decrease in lung cancer death in the CAT scan group compared to the chest x-ray group. And they followed these people over 6.5 years. There were 443 cancer deaths in the x-ray group, 356 deaths or lung cancer deaths in the CAT scan group. And so and these groups were very similar. They looked at them and said, another factor they look at is what's called all-cause mortality. What did they die from? They all died from pretty much similar things. There were more deaths than these 356 and 443, but there were similar rates of stroke and heart attack and other things. So this is the first trial to show a reduction in cancer-specific mortality. Just last year. Now, there were 2 other trials looking at CAT scan versus chest x-ray that were much smaller than the NLST, and they didn't show any difference in cancer mortality. There were 13 cohort studies. Remember, the first type of study we looked at was the cohort type trial. 15,000 patients, no change in cancer death. One study in particular was called the ILCAP trial, and it really drew a lot of criticism. Dr. Hinchke, who was the lead investigator at Cornell, first looked at 1,000 patients, and then based on that 1,000 patients said, we're going to do a larger trial. The problem is that they didn't even look at cancer mortality. They looked at all-cause mortality. Secondly, they had a very high rate of dropout from the trial. So normally, this is the kind of study that a reputable journal would look at and say, oh, your data is really bad, this doesn't look good. But this was published in the New England Journal of Medicine. Drew a lot of criticism. So ILCAP, which was the international trial, accrued 34,500 patients. New England Journal, 2006. The problem is it didn't include mortality data. They estimated a 92% 5-year survival for their stage 1 lung cancer. The problem is this was an estimate. This was a calculated number, not a measured number. They didn't have a control group. This was a cohort study. It had a lot wrong with it. So lastly, in 2008, there's a publication called The Cancer Letter. They outlined all of the problems with this study. Loss of data, they lost patient consent, which is a cardinal sin, and their dubious statistical record keeping. And then in 2008, New York Times said it received indirect funding of $3.6 million from the Liggett Group, which is a cigarette manufacturer. So it was a lot of commotion, and it set the whole, lung cancer screening talk back a few years. It really did. Well, I don't know. I don't know what their. I think it was probably on the level, but it just looks bad. It looks bad. So where do we stand with all of this? Right now, none of the major academic organizations, the American College of Chest Physicians, the American Thoracic Society, National Cancer Institute, none of them yet have recommended routine screening for what we call at-risk heavy smokers, people with smoking-related lung disease that don't have any symptoms. The U.S. Preventative Task Force also just came out and said, we second that. Right now we can't recommend it. This trial, the NLST that just finished analysis last year, will probably change that. So in JAMA, the Journal of the American Medical Association, just 2 months ago, did a very in-depth analysis of all of the lung cancer screening trials and all of the data. So their final conclusion, screening a population of individuals with a substantially elevated risk of lung cancer most likely could be performed in a manner such that benefits to accrue a few people outweigh the harms that many will experience. There are uncertainties regarding how to translate that into practice. So that's basically a fancy way of saying is low-dose CAT scan imaging for lung cancer screening is likely to be beneficial. And we finally have the one trial that is going to show it. And I think that it will be recommended for a high-risk population in the near future. So in summary, lung cancer, very deadly. The survival is very dependent upon the stage at time of diagnosis. Early detection can lead to potentially curative surgery. So far, only one large trial has shown benefit. It does have the potential for harm. And that's something that's to be stressed for anybody that decides to undergo screening. Radiation exposure, unnecessary procedures, and anxiety. Currently, lung cancer screening is not recommended routinely, but in the near future is probably going to be. So here we go. Y'all recognize these folks, right? All died of lung cancer. Joe DiMaggio, Andy Kaufman, George Harrison, Nat King Cole, Sammy Davis, Peter Jennings, Paul Newman, the original Marlboro Man, Joe Paterno, Walt Disney, the Duke, and Yul Brynner. And this is not a comprehensive list, but all these guys died of lung cancer. Mm-hmm. Yeah, if you may or may not remember, he famously did a TV commercial on his deathbed, basically, talking about the dangers of smoking. That's it.